We'll move to the next session. It's going to be chaired by Dr. Faraz Parisha and Dr. Sabir.
Thank you, Joseph sir, Spreet sir, and Bailendra sir for the excellent lecture. Now, coming to the next session. To chair the session, let me invite my dear friend, endocrinologist, Dr. Faraz Parisha. Over to you, Faraz.
Chairman of Ramachandran's Diabetes Hospital, Chennai, President, Indian Diabetes Research Foundation, Chennai, visiting Professor, Imperial College, London, recently awarded the Best Investigator Award by World Indian Diabetes Foundation based in US. He has been awarded with the Thomson Reuters Research Excellence Citation Indian Award in 2015. He's been a speaker in various national and international forums. And then he's going to speak on gut microbiota. Is it and therapeutic option in diabetes management? So over to you, Dr. Ramachandran. You can take it from here.
Yeah, good morning, everybody. I'm very happy that I could join the intelligent people today this morning, and I've been 40 minutes late, so I've been listening to Dr. Balachandran and also Dr. Jyotidev, two excellent talks. Now we'll go on to a new thing, and I also congratulate the Travancore Diabetes Research Foundation, Dr. Shabir, and also thank for inviting me for this excellent meeting. Okay, can you see my slides now?
Yes, sir. Yes, sir. Please, perfect.
All right. So I'm going to talk to you on gut microbiota, which is newer science evolving not only in diabetes but in total human health. These are my disclosures, just for the sake of my talk. And the outline today would be first just discuss about the gut microbiota can influence host health, the role of gut microbiota specifically on type 2 diabetes pathophysiology, and then we discuss there are any therapeutic options to correct this. We have a couple of drugs used in diabetes, including acarbose, which can actually reverse the dysbiosis in diabetes, which is a pathophysiological note. Okay, this is interesting. We are more bacteria than human, and these are some of the facts which are shown on the left-hand side of the slide. The human body is home to complex communities of microorganisms. The total number is estimated to be pretty high, 10 to the power of 14. That is 10 times the number of human cells per individual. So we are more a bacteria than human. The majority of the human associated microbes and the largest diversity are usually found in the gastrointestinal tract. The microbial abundance increases from the stomach to the colon. 95% of the total microbiota belongs to the families of firmicutes, bacteroidetes, actinobacteria, and proteobacteria. So when you have so much of bacteria inside the body, there should be some function. It should have some relation to health, which probably we have ignored in the past. A healthy microbiota comprises a balanced representation of symbionts, that is bacteria with health promoting functions, and pathobionts, which are bacteria that potentially induce pathology in the human body. A decrease in the symbionts or an increase in the pathobionts is called dysbiosis. So we are actually learning new terms. And this dysbiosis is likely to be triggered by a number of factors, which could be diet, stress factors, antibiotics, and of course infections, especially GI infections. So therefore, this can influence the health status of the human body. Dysbiosis has been linked to increased fat accumulation, liposaccharide-induced inflammation, insulin resistance, obesity, and the metabolic syndrome. So for the first time, instead of having any acute repercussions, we now know that the persistent dysbiosis has some relation with metabolic diseases and even cardiovascular disease. So this is an interesting topic, and it is an area of research which is opening up now. A lot has to be learned in future. We know something about it now, but we now know that this is a new science which cannot be ignored. So on the left-hand side, these are the effects of symbiosis, and it actually decreases gut permeability, it reduces endotoxemia, it reduces pro-inflammatory cytokines, and it's a beneficial one and increases insulin sensitivity. Beneficially activate molecules such as short-chain fatty acids and indoles. On the right-hand side, you have the dysbiotic gut microbiota, which increases gut permeability and produces endotoxemia, inflammation, and results in adiposity, insulin resistance, and metabolic syndrome. So therefore, that's a connection, some connection between not only just diabetes, but also cardiovascular disease and the gut. Now, specifically, we can talk about the role of gut microbiota in type 2 pathophysiology, and there have been a number of plethora of papers coming out, the connections. Intestinal flora is a hotspot in the field of diabetes in recent years, and there have been a number of papers. This is a paper which showing the metogenic wide association, and what it has been shown is that a moderate degree of gut microbial dysbiosis is seen in type 2 diabetes, decrease in the abundance of some of universal butyrate producing bacteria, and an increase in the various opportunistic pathogens. So there is still a lot of work to be done, but this is one of the findings which has been universally seen. Some mechanisms have been worked out, but a lot has to be learned. This is just showing that alteration of intestinal permeability after change in the gut microbiota has been shown in mice models, and there is an increased permeation of liposaccharides, and there's a new receptor called the toll-like receptor, which is acted on by this microbiome. So intestinal permeability and increased absorption of liposaccharides leads to metabolic endotoxemia, which is basically an elevated serum concentration of LPS. This leads to, again, this metabolic endotoxemia leads to impairment of insulin signaling. And again, this is experimental animals. At this point, we must also say the origin of metabolic endotoxemia is not very clear, but is strongly suggested that it may be associated with changes in the gut microbiota, leading to increased activation not only of inflammatory pathway, but also impaired insulin signaling. Therefore, the connection between microbiota and insulin and diabetes. This is putting all together. In fact, there has been three mechanisms which has been sorted out today. One is the TMA pathway, trimethylene N-oxide pathway. The other one is short-chain fatty acid pathway and primary and secondary bile pathway, all leading to an increased inflammation, endothelial damage, and insulin signaling. So all these have come out from experimental studies in mice. There are only very few human studies, but we know there is a connection between microbiota and type 2 diabetes. So when you put up slides on pathophysiology of type 2 diabetes, we always talk about genetics, environment, and diet is an important part of the environment. And they talk about obesity, sedentary life habits, insulin resistance. But now you have a new candidate, which is microbiota, which can be added as one of the pathophysiological or ecological factors in the pathogenesis of type 2 diabetes as well as metabolic syndrome. So you talk about genetics, environment, and the environment could be also influenced by not only your sedentary life habits, lifestyle. One important lifestyle is diet, and we only talk about high-fat diet, high-sugar diet, and high-carbohydrate diet, etc. But we must also remember diets which can change the microbiota may be involved in the pathogenesis of metabolic diseases such as type 2 diabetes. Now, it may be interesting that there are a couple of drugs which is used for diabetes which can actually show correction of the dysbiosis microbiota. One is acarbose, and the other one is interestingly metformin. So I'm going to give you a few slides to tell you some of the randomized controlled trials and experimental and cohort studies to show that. Now, what is the mechanism? Acarbose facilitates production of short-chain fatty acids and hydrogen gas by fermenting of undigested polysaccharide in the lower gastrointestinal tract. As you can see, it facilitates increased production of fatty acids in H2, which mediates suppression of pro-inflammatory cytokines and also a number of adipokines like interleukin 6, TNF-alpha, and these can be attributed to cardiovascular benefits. So you have surrogate markers, which are, we can say biomarkers, which can be influenced by the change in microbiota, which is influenced by acarbose. A question may be asked, of course, you know acarbose is an alpha-glucosidase inhibitor, whether other alpha-glucosidase inhibitors such as megalitol and voglibose, which is already in the market, has the same property. But actually, it is not so. It is only acarbose which actually produces higher concentrations of polysaccharide, and therefore it has got this specific action of correcting the dysbiosis microbiota into a less inflammatory microbiota, which actually has benefits both from the cardiovascular point of view and metabolic point of view. This is one of the studies showing acarbose treatment affects the serum levels of inflammatory cytokines and the gut contents of number of bacteria in Chinese patients. Of course, this is from Taiwan, and what is shown is a randomized control trial where 59 were in group A, where acarbose 150 milligrams per day was given, and the other was given treated without acarbose. And what is shown here is that the favorable effects on the microbiome in diabetic patients with acarbose, the levels of the bifidobacterium lognum and Enterococcus faecalis higher in patients with diabetes than in diabetic controls usually. Now, acarbose treatment significantly increased the levels of the lognum and decreased the level of Enterococcus faecalis in both the groups, which is actually correcting the dysbiosis. So this is one of the evidence to show that acarbose, which is an alpha-glucose inhibitor, increases the beneficial effects can be seen also by dysbiosis. We also know that acarbose has got an incretin effect. This is a new effect which has now been described from acarbose. There's another study showing the effect of acarbose treatment on inflammatory markers in patients with diabetes, where you have looked at TNF-alpha, high sensitivity CRP, and MCP1 decrease, and then levels of PI1 were unchanged in the acarbose group. So on one side, you have the baseline increase in the pro-inflammatory cytokines in patients, and after 4 weeks of acarbose treatment, there was a significant decrease in all the 4 biomarkers or pro-inflammatory factors, and this is mediated through the change in microbiota. So these are indirect evidences that microbiota in the gut has very important role in the pathogenesis of metabolic diseases, type 2 diabetes, cardiovascular factors, and treatment with acarbose not only does this, but you have evidence from the serum surrogate markers that probably it is working and could have long-term beneficial effects in people with type 2 diabetes who already have an inflammatory status and also have a high risk of cardiovascular disease. There's another study, effect of acarbose on gut bacteria, a randomized double-blind control crossover. What has been given is that at each follow-up visit, every participant was asked to have a standard meal with the same dose of medications, and then fecal samples was collected and brought to the laboratory within 2 hours and stored in minus 80 degrees. So it's a crossover study. You do a double-blind study, and then you give one group acarbose, and then I stop that, and then you give crossover study, you give the group which did not receive a carbose, you give the placebo, and then continue the other group on a carbose. So that gives a very robust design of study to show that. What is shown here is that total 108 genera was identified, and 40% were at relatively higher abundance after treatment with a carbose. That's a pretty high change for that short period of treatment. There was, after a carbose, higher abundance observed for 5 genera, including Lactobacillus and Dialister, and then lower abundance of these bacteria, which can produce dysbiosis. So therefore, again, this is an indirect clue that a carbose can correct the microbiota and could have a beneficial effect in the long run. So what is the beneficial effect? So Lactobacillus includes improving type 2 diabetes, anti-diabetic and anti-inflammatory effects, and of course, reducing body weight. Megasphaera could potentially transform the carbohydrates into short-chain fatty acids, which is beneficial for lactobacillus growth. So these are the actions which has been now shown from mice, and also now we know even the human microbiota, these changes can be reproduced, and a carbose can correct the symbiosis, the dysbiosis which is seen in patients with diabetes, and it could have long-term beneficial effects. Metformin is, of course, is very interesting. We have been actually, metformin is one of the oldest drugs for diabetes, and every time we study the mechanism of action of metformin, we find there are new mechanisms. Now, you know that it increases insulin sensitivity, it has got an incretin effect, it has got effect on the gut, it has got effect also now, a new effect on gut microbiota. And this is not through lactobacillus. This is another bacteria. Metformin increases the abundance of Akkermansia, a mucus-degrading gram-negative bacteria in the gut, which is associated with restoration of reduced regulatory Tegris cells, amelioration of low-grade inflammation in the adipose tissue of animals. Now, Akkermansia is called munciniphilia, has been shown to combat diabetes and obesity in obese mice. So therefore, looking into microbiota, we are finding that metformin has another new mechanism of action in reducing not only blood glucose, but also reducing cardiovascular risk by with action on microbiota. So I think it's a very new finding, and a lot needs to be done. So I'm just telling you some of the preliminary data on the connection between the GI bacteria, the metabolic diseases, cytokines, and then we are coming to whether the present treatment, some of the agents that we are already treating, has some beneficial effects on microbiota, which may have long-term beneficial effects, not only for diabetes, but also its cardiovascular complications. So the combination of acarbose and metformin, probably, when we were describing that acarbose and metformin had incretin effect, we found that when you combine acarbose and metformin, the incretin effect was amplified. So similarly, the beneficial effect of acarbose and metformin can be amplified when you give a combination of these two drugs together in type 2 diabetes through different types of bacteria and the short chain fatty acids. So another question, now all of you can now ask, till now we have been describing studies which are actually experimental studies, surrogate markers, but is there any evidence to show that acarbose has got any randomized control trials or any real world evidence to show that it has got any cardiovascular benefits? We know there have been two important studies. One is the STOP-NIDDM trial, which showed it reduces the risk of diabetes, but it also had a significant reduction in myocardial infarction. The ACE trial in patients with impaired glucose tolerance failed to show that acarbose had any cardiovascular benefits, but reduced diabetes by 16%. Now, what I'm showing here is actually real-world evidence showing that A significant lower risk with acarbose metformin combination seen in stroke, atherosclerotic, and myocardial infarction compared with sulfonylurea and metformin, almost 14,000 patients. It's pretty impressive. Of course, this is not a randomized controlled trial. This is a real-world evidence from the population data. So there has been a 33% relative risk reduction in patients treated with acarbose in hospitalization due to ischemic stroke, a 31% relative risk reduction in hospitalization due to atherosclerotic events, a 34% relative risk reduction in hospitalization due to myocardial infarction. So this is a signal showing that what we have just learned from the surrogate markers of beneficial effects of acarbose may be seen in the population in the human beings with type 2 diabetes, and we probably need more studies, more randomized controlled studies in order to see whether it can be reflected in cardiovascular benefits in patients with type 2 diabetes who are treated with. Now, this is a study, a robust study from real-world evidence from the Asian population. So to sum it up, we're talking about microbiota in the gut. Dysbiosis of the gut microbiota is increasingly appreciated as a mechanism accounting for diabetes and related metabolic diseases. Gut bacteria use polysaccharide substrates as fuel for their growth and conversion to short-chain fatty acids. Acarbose allows polysaccharides to enter the large intestine and facilitate production of short-chain fatty acids and hydrogen gas. The SCFAs, or the short-chain fatty acids, have beneficial effects on the host, energy metabolism, and inflammatory responses. In short, these are again surrogate markers, so it may have long-term beneficial effects. Acarbose treatment significantly increases levels of useful bacteria, including Bifidobacterium laudanum, Lactobacillus, and Megasphaera and Dialistum. So this is beneficial to the gut and also increases the cardiovascular protection in the long term. So this is a new, as I told you in the beginning, there is a new science, and we have to learn a lot on this. It only shows that the gut, the bacteria living in our colon, is not an innocent bystander, but maybe an active participator in causing diseases, and probably these may be targets for treating and preventing diabetes and cardiovascular disease in future. Thank you.
So thank you, Ramendra sir, for the excellent lecture. Faraz, can you unmute? Yeah. We will have some couple of questions right now.
Yeah, am I audible now?
Yeah, perfect. Please go ahead.
Yeah, so thank you, sir, for that impeccable presentation on gut microbiota. And then I would agree that it is ever-changing science. And then I'm really surprised that with the COVID pandemic, that gut microbiota has not been till now linked to COVID, because now gut microbiota has shown benefits in all the points of the. You talk about diabetes, you talk about obesity, hypertension, and then there is FMT, that is the microbiome transplantation also, there is, which has been done in AIMS as well. So definitely it is future which we are looking ahead.
Sure. Yeah, that's a good thing. Yeah. We are learning about COVID every day or every hour with the new science coming out. And the connection between diabetes and COVID is, I was involved in that same article which you were talking about. At this point of time, I am involved in a global diabetes registry where we are looking at new onset diabetes due to COVID, because we find that a lot of people with COVID are getting new diabetes. It's not an autoimmune reaction. We do not have still any data on microbiota and COVID at this point of time. We only know that COVID also can present with diarrhea and GI disturbances. There are a variety of presentations of COVID being seen because there are millions of patients who are contracting this virus. So we are learning every day. You're right.
So we'll now move to the next session.
Thank you.
Thank you, sir. So we'll now move to next session. I'll invite Dr. Tahsin M. He is an interventional cardiologist at Malabar Institute of Medical Science, Malappuram. completed DM from Calicut Medical College, speaker for many regional and national conferences. And he will be speaking on Depaglifozin, a new standard of care in heart failure management. I think, again, SGL2 is one drug which all of us are learning that it is one drug which is an anti-metabolic syndrome drug. So let us hear it from Dr. Tahsin. Over to you, Dr. Tahsin.
Good afternoon, all. Hope I'm audible to you.
Yes.
Thank you for this opportunity to talk in front of you. Thank you, Dr. Sabir, and all the other participants and the organizers for this chance to talk. And as you all know, the Depaglifozin and heart failure, it is the hot topic because all the glyphosins started as a diabetic drug, and now it is in the arena of the cardiologist. And we are so happy that we got one more drug to treat the patients who are suffering from heart failure. So SGLT2 inhibitors were added as an add-on OHA, and it included DAPA, EMPA, CANA, and Depaglifozin. The mechanism was renal excretion of glucose through this SGLT2 inhibition, and it produces osmotic diuresis. And the previous studies showed it has got a very good cardiovascular and renal safety. And those studies also hinted that it reduced heart failure admissions in diabetic populations. So now the golden question that came up after these studies is there any benefit for non-diabetic heart failure patients? Is there any benefit for non-diabetic heart failure patients on top of best available therapy? That includes medicines like AC inhibitors, ARB, beta blockers, and including devices like CRT and CRT kind of devices. So this is the golden question that we wanted to answer. And for that, this trial was designed. That is the DAPA-HF trial. And the design of the DAPA-HF was, it included around 4,744 patients. That's very good inclusion. And it was conducted in 20 countries. And the inclusion criteria were, one, the patient should be symptomatic, that is NYHA class 2 to 4, and the ejection fraction should be less than or equal to 40%. And there should be signs of evidence for the heart failure, like NT-proBNP should be more than 600 picogram per ml. There are some extensions for that. I'm not going into the details. The exclusion criteria included severe renal dysfunction like EGFR of less than 30 ml, EGFR of 30 ml, and a systolic BP of less than 95 milliliters of mercury, and all the type 1 diabetes patients. And they were enrolled equally, 2,371 in the placebo group and 2,373 in the Depaglifozin group. And the study was published in, it was conducted across the globe in all the continents, main continents, and most of the patients were recruited from the Europe. And the key baseline characteristics of these patients, I just want you to focus on these areas. One is class 2 patients were more. That is, NYHA class 2 patients were 68%, and the mean ejection fraction was 31%, and 45% patients had diabetes. That means 55% didn't have diabetes. So it's a balance. 50%, around 50% of the patients were diabetic, 50% were non-diabetic, so that we can compare the results into both the groups. And most of other parameters were matched very well. And most of the patients were on diuretic, 93% and 94%. That means the diuretic effect of Depaglifozin doesn't have much effect on these patients. And the patients were either on AC inhibitors 56%, ARB or ARNI, that is sacubitril valsartan group. And altogether this comes around more than 90%. And more than 96% was on beta blockers, and mineralocorticoid receptor antagonists, spironolactone or eplerenone were used in 71%. And the best device therapy like ICD and CRT were used for these patients whenever it is possible and indicated. So the baseline was well balanced, and all the patients were given the best treatment available other than the DAPA for the control of heart failure, and all were symptomatic. Major chunk of these symptomatic patients were in the NYHA class 2 group. And the results were published in 2019 in the New England Journal of Medicine. And the primary outcome was, this is not surprising because previous data about other drugs were also showing these data, were indicating the benefit. The primary composite outcome of cardiovascular death, heart failure hospitalization, or urgent heart failure visit were much less in the Depaglifozin starting from the very beginning. So immediate effect and long-lasting effect. And it has got a hazard ratio of 0.74 with a very narrow confidence interval of 0.65 to 0.85. That makes it so significant with the p-value much less than 1 in 10,000. The number needed to treat was 21. So it all says that the cardiovascular death, heart failure hospitalization, and urgent heart failure visits were much better in the Depaglifozin. And when we separate these items, the worsening heart failure event, it was much less in the DAPA with a hazard ratio of 0.7, and cardiovascular death itself was significant, even though the p-value is not that important. So major benefit were coming from the prevention of heart failure worsening, and on top of that, there is an additional benefit with reduction in cardiovascular death. Then the secondary outcomes of this trial showed the cardiovascular death or hospitalization. Again, that also the DAPA was good compared or better than the placebo from the beginning itself. You can see that even within 1 month, both the curves were separated, and the hazard ratio was 0.75. And the total heart failure hospitalization and CV death, including first and repeat hospitalization, DAPA was superior. So the question, till now we were discussing about the acute worsening and acute hard endpoints in the course of a patient's life. What about the in-between time? We know that if we are giving Depaglifozin to 100 patients, their acute worsening, acute admissions, and sudden death or death due to cardiovascular cause are less. What about the intervening period? Whether they have an important, significant, symptomatic benefit out of DAPA? That was the next question. And that question was answered by comparing the Kansas City Cardiomyopathy Questionnaire, KCCQ. It's from 0 to 100. The questionnaire is from 0 to 100. And the DAPA patients had a change, improvement. When it goes up, the score goes up, that means there is more improvement. The DAPA had a plus 6.1 point improvement, whereas the placebo had only plus 3.3 point improvement, with a significant difference between the DAPA group and the placebo group. So that means that when you start the patient on Depaglifozin, the patient immediately gets the benefit, symptomatic benefit, and in meantime, it prevents the sudden worsening of heart failure and also the cardiovascular death. So altogether, there is improvement. When we check the point score, this KCCQ, more than 5 points improvement is required to say that there is an improvement. So how many percentage of patients had this improvement? In the DAPA group, it's 58%. In the placebo group, it's only 51%. And it's significant. And again, the deterioration also. Some of them deteriorated even on DAPA and placebo, but that deterioration was much less in the DAPA group. That is, it's only 25% compared to 33% in the placebo group. So the placebo, it was also statistically significant. So these are the outcomes, the hard endpoints. And all-cause death, that's also a secondary endpoint. all-cause death was also less in the DAPA group, but you can take it that the p-value is only 0.02, but the hazard ratio of 0.83 with a wide confidence interval of 0.71 to 0.97. I think this point we should not be focused. We should not be focusing on the all-cause death or the cardiovascular death. My point is basically the heart failure component, acute worsening, as well as the continuous symptomatic improvement of the patients on top medical management and device therapy. This medicine has got an additional benefit over the placebo. That was the result. And what about the safety? From the previous trials, we had so many concerns regarding this molecule, this group of molecules, these gliflozins. And these safety concerns were analyzed in these trials also. Patients exposed to at least one drug were analyzed. So adverse events, volume depletion, because this drug has got an osmotic diuretic property. So volume depletion leading to BP fall or elevation in creatinine can happen. But when compared to DAPA to placebo, there was no significant difference in these two groups regarding the volume depletion. And renal adverse events, again 6.5 versus 7.2. When fractures were similar, it can cause osteoporosis. Then amputation, in Depaglifozin study, we know that there was slight increase in the amputation rate. And again in DAPA study, this heart failure study, it's only 0.5 and 0.5, both are same. Major hypoglycemia is the same in both groups, and diabetic ketoacidosis, because of volume depletion, diabetic ketoacidosis can occur, but still it is not significant. So adverse events leading to treatment discontinuation was similar, and any serious adverse events, including death, was also similar in both the groups. And volume depletion, again, if we are taking it separate, depletion serious, because both the groups didn't have much difference compared to DAPA and compared to placebo. DAPA didn't have much increase in the volume depletion. Then renal safety. The previous studies showed that over a long-term period, the renal function is stabilized because of gliflozins. But in the acute setting, it can cause reduction it can produce acute kidney injury because of the compounding effect of diuretics with this drug. So the renal safety is separately measured, assessed, and the renal adverse events were the same in both the groups, 153 versus 170. Serious renal adverse events were much less in the DAPA group, which was much significantly reduced in the DAPA group. And renal adverse events leading to discontinuation is same, and serious acute kidney injury was also much less in the DAPA group. And what we look, these are the acute presentations. And what about the long term, over a period of time, how the creatinine goes when we are starting this patient on DAPA? That is the doubling of serum creatinine. The doubling of serum creatinine was much less in the DAPA group compared to the placebo group, and it is actually significant, statistically significant. So altogether, then the next problem that we used to see was the recurrent urinary tract infections and genital infections, especially candidiasis in females. And compared to placebo, urinary tract infections and urosepsis was similar to placebo in the Depaglifozin group, and there was no significant difference between these two groups. But if you see the genital infections and the side effects on genital infections leading to discontinuation, it was there in the Depaglifozin group. Basically, it was the genital candidiasis in this trial. Then hypoglycemia, decay, and Fournier's gangrene, all these are potential side effects of DAPA. And major hypoglycemia, we already discussed, there was no significant difference between these two groups. And diabetic ketoacidosis, it was not, there was a non-significant increase in the DKA in the study group. And Fournier's gangrene actually happened in the placebo group, not in the DAPA group. It was only one case. So all these complications happened in the diabetes subgroup, basically because they are more prone and there will be additional drugs on top of this to cause the hypoglycemia. Then subgroup analysis to compare the diabetics versus non-diabetes. This is the question of the study, whether this drug is effective in non-diabetes, whether it is as good as in the diabetes population. So in the diabetes population, the hazard ratio is 0.75. And in non-diabetes, it is actually 0.73. So it's more effective or equally effective compared to the placebo to prevent the cardiovascular death, heart failure hospitalization, and urgent heart failure visits. So this drug is effective, and the benefit of this drug in the heart failure patient population is independent of its diabetes control, and it is maybe independent of its diuretic effect. It has got some other mechanisms. So many postulated mechanisms are there for these benefits for DAPA and other gliflozins. Benefit seen irrespective of EGFR status. That's another point. Some studies show that the benefits of gliflozins decreased when the EGFR is coming down, especially it is close to 30 ml. But in this study, even if the EGFR is less than 60 or more than 60, the benefit is almost same. And this is very well depicted in this picture. As the EGFR is coming down, the benefit is improved. This is better. DAPA is better than the placebo. Here the DAPA is far, far better than the placebo, and the hazard ratio is 0.4. So there are studies and there are sub-analysis and meta-analysis showing that gliflozin's effect comes down, especially its anti-diabetic effect comes down when the EGFR is coming down. But its heart failure benefit is not coming down with the reduction in the EGFR. Then there is an interesting point that we already discussed, that is a 44% reduction in the incidence of acute kidney injury that I already showed the data. That the DAPA group, it is 1.8%, and the placebo group is 3.2%. And DAPA reduces the acute kidney injury. So in the nutshell, the take-home message from these trials, these data, is that Depaglifozin and all other gliflozins, maybe, we don't know, reduces heart failure admissions and death. It reduces heart failure symptoms that is happening in between these acute heart failure admissions. And it is safe to administer this drug. It is renally safe. It has got very good side effect profile. And it is effective in both diabetics and non-diabetics. That is the point. And we should watch for the volume depletion, and we should watch for the DKA, and we should estimate the EGFR frequently to avoid complications. And in my experience, that happened in actually 2.5 years back, I remember. A patient was on all the medical therapy, but she was not at all improving. It was an ischemic cardiomyopathy with severe obstruction. And I started the patient on Depaglifozin. And she improved. And after around 2 months, because of the cost of Jardiance, they requested me to stop Jardiance. I stopped Jardiance. The next week, she got admitted with acute pulmonary edema. Then I restarted her on Jardiance again. Then again, this patient was on Jardiance. Again, I stopped the medicines personally without telling them. The patient again got admitted. Third time, when I was asking them, this is costly, should I cut it down? They told that you can cut all the medicines, but not Jardiance, because whenever you are cutting Jardiance, she is getting admitted, and we are losing a lot of money on admission. So that is my personal experience regarding the gliflozins. And regarding the when to start gliflozin for heart failure, that is the difficult question that now we have. In my practice, what I'm doing is, all diabetic patients, if they have symptomatic heart failure, I used to start gliflozins before the ARNI, that is the sacubitril/valsartan combination, because both are costly, both has got definite benefit in heart failure, but this has got an additional benefit because the patient is diabetic. We'll get a better diabetic control, weight loss, and all those things. definitely before devices in patients with diabetic symptomatic heart failure. Whereas in non-diabetic symptomatic heart failure, I prefer to start ARNI first, then I'll go for glifosins, definitely before the devices. These are my thoughts on when to start glifosins without any evidence, without much evidence from the literature. Thank you so much for the patient listening. I hope I'll get more information from you because you all are using this medicine more than us.
Thank you so much, Dr. Tahsin, for this elaborative on the study of DAPA-HF. I think we were never surprised, and now also I'm never surprised because SGLT2 molecule has been taken over more by the cardiologist than by the endos or the physicians or the other groups. Just because considering the pleiotropic benefits what it has, leaving the glycemic. So of course, we are not so much concerned or not enthusiastic about the glycemic benefits, but we are definitely looking at the other pleiotropic benefits which the entire group has. And even the 2018 ADA ESD consensus have also clearly endorsed on what you were saying, that if you have any patients with diabetes with pre-existing history of heart failure or CKD, then after metformin, it has to be SGLT2 inhibitors. So thank you so much for that elaborative lecture. And then over to you, Dr. Sabir.
Thank you, Faraz. Thank you, Dr. Tahsin and Dr. Ramachandran sir, for their wonderful lectures. If there are any questions to Dr. Tahsin, I think we can take it now. Just one question. Dr. Faraz, you need to comment something?
Okay.
No, if there are no more questions, I think we will go straight away into the next session.
I think he has already answered
Faraz,
most of
it's
them.
not clear, Odi.
I think we will go to the next session.
Okay, perfect. So we'll move on to the next session. Next session is something related to the role of vitamin B12 and vitamin D in metabolic syndrome. So for this, we have an eminent speaker from Cochin, Dr. Bobby K. Mathew. Dr. Bobby Mathew is my very close friend. He's the senior consultant endocrinologist at Wellcare Hospital, Cochin. He did his DM from KEM Mumbai. And I think his way of presentation and way of lecture is very peculiar and very interesting, and is attracting hundreds of many medical professionals. So he has presented papers in more than 100 national and international conferences. Over to you, Bobby.
Yeah, slide. Something about metabolic syndrome, vitamin D and vitamin B12, nothing. 90% of diabetes that we see is type 2 diabetes and 10% is type 1 diabetes. We know that type 2 as well as type 1 diabetes is on a rise. Open Harrison used to tell us that 90% of type 2 diabetes people have a BMI more than 30. That is known as diabetes or metabolic syndrome. Now, invariably, we know Indian studies have shown that up to 50% of the type 2 diabetic that we see in our OPD doesn't have a BMI more than 30. Up to 50% of type 2 diabetes that we see in our OPD have a BMI between 23 to 30. Many times we see morbidly obese ladies coming to the OPD with a body weight of 120 kilogram. We think that they'll be coming for evaluation of HbA1c. You check their HbA1c, it comes to be 5.5 or 5.6. They'll be showing you 0.5 or 5, thinking that subclinical hypothyroidism is causing weight gain. You look at this lady having massive amount of fat in her abdomen, thighs, breast or buttocks, but her HbA1c is hardly 5.5. By the side of this massively obese lady, maybe a thin calcic husband who will tell you, no doctor, she's not diabetic, doctor, I am diabetic. I checked my HbA1c 3 months back, my HbA1c is more than 9. This guy with a small pouch of abdomen has an HbA1c more than 9, whereas this lady having a massive amount of fat in her breast, thighs or buttocks hardly have an HbA1c of 5.5. That is known as a thin, obese Indian phenotype. An Indian may be looking thin externally, but he or she can be obese internally. Just to understand that, think of a person like me, age 43, 44 years, with an abdominal girth 95 centimeter, with a grade 2 obesity. You take a US citizen with the same abdominal girth as that of me. You take a CT scan abdomen at L4, L5 level of me as well as the US citizen. Indian with the same abdominal girth is thought to have 3 to 5 times much higher visceral or intra-abdominal fat mass compared to the Western person. That is, an Indian may be looking thin externally, but we are obese internally because of the increased piling up of visceral fat. This itself explains why 99% of Indian type 2 diabetes, the moment you diagnose a type 2 diabetes, you go for an ultrasound abdomen, it shows a grade 1 to grade 2 fat liver disease. That shows that our subcutaneous fat is less, whereas our visceral fat is much more higher. And abdomen, if you have high chance of type 2 diabetes compared to female having a largest amount of fat in their thighs, breasts, or buttocks. So basically understand, we all studied in MBBS, abdominal fat is divided into two components: subcutaneous fat, that is behind our skin, and visceral fat, that is yellow fat in and around the omentum. Subcutaneous fat is an inert fat, it doesn't cause any complication at all, but visceral adipocyte is thought to be highly metabolically active. That is, triglyceride stored in the visceral adipocytes gets easily broken down to glycerol and free fatty acids. And these free fatty acids drain directly via portal circulation to the liver, causing a hepatic insulin resistance and fatty liver. That is, our subcutaneous fat drains to the peripheral capillaries, whereas our visceral fat drains to the liver, causing hepatic insulin resistance. This explains why liposuction, which is a cosmetic surgery to reduce our body weight, never controls our HbA1c, whereas a bariatric surgery, either a banding or a bypass, which reduces the visceral fat, reduces the HbA1c. That is, liposuction is a cosmetic surgery, whereas a bariatric surgery is a metabolic surgery. Second point, understand, when we all used to study for MBBS MD, we used to think that thyroid gland is the largest endocrine gland in the body. Now we know it is the adipose tissue, which was once considered a waste energy depot, that is now considered to be the largest endocrine gland in the body, because adipose tissue produces a host of hormone, right from leptin to resistin to adiponectin to angiotensin to estrogen. Leave it. Basically understand, Indian is having a thin, obese Indian phenotype. So whenever you see an Indian with a BMI more than 23, you see or you check all the parameters of metabolic syndrome that you examine for a Western person with a BMI more than 30. It is not the subcutaneous fat that is important, it's the metabolically active visceral fat that contributes to metabolic syndrome, insulin resistance, and type 2 diabetes. Now we know fatty liver is having a major chunk in the counterpart of metabolic syndrome. Suppose you are having a female who comes to a gynecologist for evaluation of PCOD. She is doing an ultrasound abdomen, not an ultrasound pelvis. It shows a grade 1 to grade 2 fat liver disease with a PCOS. So invariably, the patient or a young lady, 25-30 years, is having a fat liver disease. You are first asking the patient whether she has any history of alcohol in the exit. She has never taken alcohol in her life. You are doing the hepatic markers, HbSAg, anti-HCV, ferritin, all the hepatic markers are negative. You are doing the LFT. LFT shows SGOT, SGPT elevated. So ultrasound showing a grade 1 to grade 2 fat liver disease with an LFT showing SGOT, SGPT elevated. That's a pure NASH. How do you deal with the NASH now? Diet, exercise, weight loss reduces NASH by 31%. Metformin 850 mg BD reduces NASH by 58%. Pioglitazone, which was once thrown out due to bladder controversy, osteoporosis controversy, is now considered the drug of choice of NASH. Pioglitazone in dose of 30 to 45 mg reduces NASH by 75%. So metformin reduces NASH by 58%. Pioglitazone reduces NASH by 75%. Statin, fibrate, vitamin E, 400 mg BD, orlistat, and the SGOT inhibitor can reduce NASH by 20%. And understand, don't think that every person with an ultrasound showing a fat liver disease is going to die of a fat liver carcinoma or a liver failure person. Nothing. 75% of the people with a fat liver disease die of nothing but a coronary artery disease. 20% die of cancers other than liver cancer. Maybe a CA breast, CA colon, CA endometrium. Only 5% of the patients where your ultrasound or LFT shows a fat liver disease going to die of a hepatocellular carcinoma or a liver failure or a ketogenic cirrhosis. So fat liver is a marker of metabolic syndrome, insulin resistance. Your diet, exercise, metformin, pioglitazone, statin, and vitamin E is going to prevent your fat liver from progression to ketogenic cirrhosis and hepatocellular carcinoma. And now the concept of metabolic syndrome that we know: abdominal obesity more than 80 centimeter in a female, more than 90 centimeter in a male, a fasting blood sugar more than 100, a BP more than 130 by 85, a triglyceride more than 150 in both male and female, and HDL less than 40 in a male, less than 50 in a female. This you and me knows because we have been studying in Harrison or Davidson right from 1995, the relevance criteria or the three-quarter TV. What is the extended criteria for metabolic syndrome? Look at this. Now these are the extended criteria for metabolic syndrome: hyperuricemia, NASH, hypogonadism, increase in small dense LDL, microalbuminuria, polycystic ovary syndrome, obstructive sleep apnea, and subclinical hypothyroidism. Don't go into it. Just understand an obese person coming to you with high uric acid is no longer gout. It is a part of metabolic syndrome. Your diet, exercise, weight loss, metformin, pioglitazone, losartan potassium or telmisartan, your SGLT limiter, your DAPA, CANA, EMBA, as well as fenofibrate, everything, and bring down your uric acid to a level less than 6 milligram. An obese person, a middle-aged guy, 35 or 40 years, coming to you with decreased libido with an erectile dysfunction, where you are checking the total testosterone, it is coming to be less than 3.5 nanogram per ml. That is also a part of metabolic syndrome. You ask the patient for a diet, exercise, and weight loss and reduction of the BMI from 40 to 25, testosterone invariably increases because of the reduction in insulin resistance. And subclinical hypothyroidism. Look at the last sentence which I have written. The extended counterpart of metabolic syndrome is hyperuricemia, NASH, hypogonadism, increase in small and cell DL, microalbuminuria, PCOS, and subclinical hypo. We know that whenever you see a TSH more than 10, it should be treated. It is known as overt hypothyroidism. A TSH 4.5 to 10 in between is known as subclinical hypothyroidism. You treat a subclinical hypothyroidism with a TSH between 4.5 to 10 if your antibody is positive. If your antibody is negative, you treat a subclinical hypothyroidism when there is goiter or the patient is having infertility treatment or in pregnancy. Why did I tell that? Even now, females come to the OPD and tell the doctor, I am having hypothyroidism. I'm taking thyroxine, doctor. My TSH is 1, but still I am not losing weight. Even now, because just like the sir was telling about the statin controversy, even now physicians sends patient to an endocrinologist think that she's hypothyroid, not gaining weight, so do the metabolic evaluation. Does hypothyroidism actually cause weight gain? Now studies have shown that the maximum weight gain associated with severe, long-lasting, untreated hypothyroidism with a TSH of more than 100 is thought to be between 1.5 to 2 kilograms. If the maximum weight gain in a person who is living with a TSH more than 100 is 1.5 to 2 kilograms, the maximum weight gain associated with subclinical hypothyroidism between TSH of 4.5 to 10 is thought to be somewhere between 20 to 40 grams. So hypothyroidism is the most common association of obese ladies. Ladies gain maximum weight after pregnancy, and most common time period in the life of a female where hypothyroidism due to Hashimoto occurs also in the postpartum period. So hypothyroidism never causes obesity, vice versa. Obesity can cause subclinical hypothyroidism due to leptin resistance. So whenever you see a TSH 4.5 to 10 with antibody negative in an obese person, don't start thyroxine. Ask the patient for a diet, exercise, weight loss, and metformin, and even bariatric surgery can reduce the TSH to normal. So understand, metabolic syndrome doesn't mean that the patient is just obese. It's a syndrome beyond diabetes, hypertension, hyperlipidemia, where you have increased risk factor for all these factors. From this, I'll be going to vitamin D. Now I have only 30. So basically, vitamin D we all know, but what we forget is what we have studied in MBBS, in Ghana, on Chiton, the basic thing. Even now we know some doctors get confused whether to like shell cal, what is the calcium. Some people like shell cal CT, some people like shell cal HD, and how much dose of vitamin D should be given in pregnancy, how much dose of vitamin D in a menopausal lady. Suppose my mother, 70 years, coming with osteoporosis, what's the dose of vitamin D? The absolute criteria many times people forget. So basically, understand about vitamin D, go through this slide, what you have taken from Ghana only. Sunlight falling to the skin. It converts 7-dehydrocholesterol to cholecalciferol, that is vitamin D3. The form of vitamin D3 that is present in almost all the calcium preparation that we write, right from shell cal to McCalvic to D-Rice to D3K tablets, everything contains vitamin D3 or cholecalciferol. Cholecalciferol gets 25 hydroxylated in the liver to form 25 hydroxy vitamin D3, and 25 hydroxy vitamin D3 gets 1 alpha hydroxylate in the kidney to form 125 dihydroxy vitamin D3, that is calciferol. So understand two things. Vitamin D3, suppose you take a shell cal tablet, which we all have been hearing for the past 35 years. My mother probably has menopausal lady for past 20 years. She has been put by an orthopedist on shell cal for past 20 years. She still continues that. So what does shell cal 500 contains? It contains calcium carbonate 500 milligram with 250 international units of vitamin D3 or calcium or cholecalciferol. And what is calciferol? Calciferol is shell cal CT, or calciferol is always in 0.25 microgram, whereas vitamin D3 or cholecalciferol, it is 500, 1000, 2000 or 60,000 that we see. In the conditions you require vitamin D, let it be rickets, let it be osteomalacia, let it be osteopenia or osteoarthritis, you have to take vitamin D3, not calciferol. Suppose you have a small child at the age of 5 years coming to you with bilateral rickets, just like the practical patient I saw 3 months back before lockdown when I was in Dubai or Sharjah, a young Arab lady bought their third child, 5-year-old boy, who was having bilateral nutritional vitamin deficient rickets with bilateral genu valgum. Serum calcium was 5.5, phosphorus was 2.2, alkaline phosphatase were around 15,000. X-ray risk shows metaphyseal cupping, fraying, widening, what all we study for MBBS. They are taken to an orthopedician. Orthopedician was giving the equivalent of Shelcal International Band Osteocare tablet 500 mg 3 times daily and a calcitrol capsule 0.25 microgram 3 times daily. So the boy 5 years with nutritional rickets was diagnosed with a calcium 5.5 3 months back. She came to me in March of 12 before lockdown when I came here. So that time the child's calcium was 10.1 milligram percentage. Calcium increased from 5.5 to 10.1, but still the child was having painful bilateral genu valgum. So that is not a vitamin D supplementation. So that child should be put on injection of arachital or vitamin D3, 3 lakh single IM shot, or a 60,000 of vitamin D3 sachet, 1 sachet per week for 6 weeks. Because whenever you give vitamin D, that will be 25 hydroxy to 25 hydroxy vitamin D3 and 1 alpha hydroxy to 125 dihydroxy vitamin D3, and rickets can be cured. So your calcium can be corrected with calcitrol, but your vitamin D deficiency can never be cured. Only 2 conditions where therapeutically 125 dihydroxy vitamin D3 or calcitrol is approved by US FDA is hypoparathyroidism and renal osteodystrophy. Understand? Normally, when you think of vitamin D, it is vitamin D3, arachital, the same is always 3 lakh or 6 lakh IM. We get it 22 rupees, or a D-rice sachet or with D3 6 tablets, which you get for 20 rupees. Calcitrol is whatever Shelcal, CP, Gemcal, whatever preparation. It is 500 milligram of calcium carbonate with 0.25 microgram of 125 dihydroxy vitamin D. That is required in hypoparathyroidism, renal osteodystrophy. The same scenario. 3 weeks back, I had a patient admitted to the hospital with very bad carpopedal spasm with seizure. The patient had done a total thyroidectomy for a papillary carcinoma thyroid 3 weeks back. So after the total thyroidectomy, the surgeon had put her on a Shelcal or whatever Macalvi tablet 3 times daily. 5th day, she had a very bad carpal spasm with some amount of stridor. She was taken to the local hospital. There was she was given 10% of 10 ml calcium 3 times. And on the 3rd day, again the stridor and carpal spasm continued. They phoned the surgeon. Surgeon asked to increase the Shelcal tablet 111 to 333. Again, after 5 days, she had a mild amount of tonic-clonic seizure. The surgeon told, no problem, increase the calcium to 555. So the patient was taking Shelcal 500 milligram, 5 tablet morning, 5 tablet noon, 5 tablet in the evening. That is 15 tablets per day. Still, when the patient got admitted with very bad carpal spasm with a stridor, the calcium was fine. What is happening? Because that is hypoparathyroidism. How much dose of vitamin D3 you give? There is no parathyroid, PTH or parathormone to convert the 25 hydroxy vitamin D3 to 125 dihydroxy. That is the condition where you require calcitrol. That patient was converted from simple Shelcal 500 milligram 555 to Shelcal CT, 1 in the morning, 1 in the noon, 1 in the evening. 3rd day, the patient calcium rose up to 8 and the patient was discharged. So understand, simple vitamin D, simple calcium, anything area vitamin D, nothing. The simple thing, the formulation change. So vitamin D3 is there, 125 dihydroxy vitamin D3 calcitrol, that is in 0.25 microgram. Give it in conditions of hypopara or renal osteodystrophy. We know that we get vitamin D from sunlight. But what is the actual hours of sun exposure that is required per week for adequate vitamin D synthesis? Understand it's clearly all the guidelines. You require 2 hours of sun exposure per week in a person who is fully covered with exposure of the face and dorsum of hand and feet, or you require 30 minutes of sun exposure per week in a person who is wearing only a diaper. So in a person who goes to the OPD, we are wearing a full kai shirt and pants with the shoes. We get sun exposure in the face, that too if you look upwards, or the dorsum of hand only. Feet is also covered by shoes. The average time requirement for vitamin D synthesis per day is 18 minutes of sun exposure. Average time exposure for sunlight exposure time for an Indian doctor is thought to be somewhere between 1.5 to 2 minutes. So you can't go to the sunlight in 11 to 3 o'clock and remove your shirt and go and get a sunlight of 80 minutes. 99% of we doctors or whatever in-house treatment doctors should take vitamin D supplementation. And what is the best time to get a sunlight for adequate vitamin D synthesis? It is the early morning sunlight of 7 to 9 or mid-noon sunlight of 11 to 3. Even now we have seen many doctors, no problem, morning sunlight is very good. No, early morning sunlight 7 to 9 is UVA, which we have studied 320 to 400 nanometer. That is for PUA therapy for psoriasis and vitiligo. Whenever you have to synthesize vitamin D by getting sun exposure, it's the mid-noon sun exposure between 11 to 3 3 o'clock. So that is the UVB of 290 to 320 nanometer. That you have to get 18 minutes of sun exposure per day. So basic things, understand clearly. Vitamin D3 is cholecalciferol. That is the shell cal, metcal with D-rise with D360K. Calciferol is your CT preparations where you give only for hypoparathyroidism, brain loss to dystrophy. Suppose you want to get adequate sunlight exposure and synthesis vitamin D by your skin yourself, go and stand in the sunlight between 11 to 3 o'clock, get UVB of 290 to 320 nanometer for at least 18 minutes. In spite of adequate sunlight exposure, vitamin D synthesis may be poor in black skin people, people wearing parda, elderly people, obese people where vitamin D is getting sequestrated, people in the urban population because of the ozone layer and winter climate. And how do you check vitamin D? Suppose you have a form of PDRC or a Medivision or a Metropolis, they have three fitting vitamin D3, 25 hydroxy vitamin D3 and 125 hydroxy vitamin D3. Whenever you have to check for the vitamin D store in the body, always check the last sentence. It should be 25 hydroxy vitamin D3, which gives the maximum faithful representation of vitamin D store in the body. So 25 hydroxy vitamin D3 has a half-life of 2 to 3 weeks, whereas 125 hydroxy vitamin D3 has a half-life of 6 to 8 hours only. So whenever you have to check vitamin D status of your child or your pregnant wife, of your grandmother or a mother who is osteoporotic, always write 25 hydroxy vitamin D3. And this slide, understand, these are all international recommendations now by international endocrine associations. So basically understand each sentence, the minimum level of 25 hydroxy vitamin D3 for the skeletal, non-skeletal effects is 30 nanogram per ml. So minimally it should be 30, preferably it should be 40 to 60 nanogram per ml. And vitamin D level less than 20 nanogram per ml is vitamin D deficiency, 20 to 30 is insufficient. Just understand two things. Minimum level is 30. Preferably keep your vitamin D level 25 hydroxy vitamin D3, 40 to 60, less than 20 is deficiency. And understand the last sentence. You require 2000 to 4000 international units of vitamin D3 intake per day to keep your 25 hydroxy vitamin D3 in the preferable range of 40 to 60 nanogram per ml. What is the importance of this? Whenever we used to study, I finished MBBS Trivandrum Medical in 93-99, MD Trivandrum Medical in 2000-2003. That time MCQ, the frequent question taken from SPM part. What is the RD of vitamin D 20 to 50 years, 200 units, 50 to 70 years, 400 units. So we have never heard a dose of vitamin D more than 400 international units. Now we know you require at least 2000 to 4000 international units of vitamin D3 per day to keep your 25 hydroxy vitamin D in the preferable range above 40 to 60 nanogram per ml. Suppose the whole shell cal preparation you are taking, it contains only 250 IU of vitamin D3. So my mother is having 70 years. She requires 2000 IU of vitamin D3. She has to take 8 tablets of shell cal. That will give her 4 gram of calcium as well as 2000 IU of vitamin D3. So she doesn't require that. That is why now the newer preparations of VD, Caltayo, everything contains 2000 IU of vitamin D3 plus 1000 milligram elemental calcium. So always understand the minimum requirement of vitamin D3 per day, irrespective of right from a newborn child to an elderly of 100 or 120 years, is somewhere between 2000 to 6000 units. Average in an Indian is 2000 to 4000 units per day. And understand about this slide. Vitamin D is Kumar and Clark Davidson, same slide. Look at the left side. Vitamin D is implicated in the pathogens of dementia, to depression, to schizophrenia, to upper respiratory infection, to lower respiratory infection, to tuberculosis, to coronary heart disease, to bone pain, to muscle weakness, to osteopenia, to osteoporosis, to osteoarthritis. Leave it. You know that vitamin D is a sunshine vitamin. You are not getting vitamin D by sunlight, or it's a cloudy climate, you are in the urban city or winter climate, is that take a vitamin D. It is not like promoting a growth hormone which may cost you 50,000 per month. It is not like promoting a newer insulin analog which may cost you 15,000 or a Victoza which costs you 12,000 per month. It is just a simple tablet which costs you 20 rupees per week. A vitamin D tablet per week or a sachet per week costs you 20 rupees. So weekly once for 8 weeks followed by 1 sachet or tablet per month. So annual treatment may cost only 250 rupees. So no controversy about vitamin D. Some benefit somewhere, maybe dementia, depression, osteopenia, your muscle contractility, your memory, your Parkinson's, your corona. You get some benefit, go for it. As doctors or healthcare practitioners, we should not have our vitamin D less than 40, preferably keep it 40 to 60 nanogram per ml. And understand this slide, because I have to go for vitamin B12 also. So basically understand this slide. This is what upper respiratory infection, coronavirus and vitamin D level. Whenever you keep your vitamin D in the preferable range of 40 to 60 nanogram per ml, you can reduce the upper respiratory infection, especially viral infection of croup or bronchiolitis in child by 90%, reduce the chance of influenza by 27%, and reduce the chance of pulmonary tuberculosis by 50%. What more you need? Vitamin D has a pivotal role in reduction of infection, especially upper respiratory infection. I've told you macrophages contains and 1-alpha hydroxylase. Whenever you load with vitamin D, this 25 hydroxy vitamin D in the macrophages get converted converted to 125 dihydroxy vitamin D3, which increases the leukocyte activation, chemotax, and phagocytosis. And invariably, we know vitamin D promotes scaffolding, whatever. It's an inflammatory cytokine, but it is an anti-inflammatory and antimicrobial peptide per day. So, whatever studies in coronavirus and vitamin D, with Jodesh visiting that, go for the next slide. So basically, internationally now for the past 8 months, so many studies have been conducted comparing severity of coronavirus with vitamin D. Invariably, all the studies have shown that people with the most severe of the coronavirus infection or corona complication at the lowest level of 25-hydroxy vitamin D level, and people with the highest level of 25-hydroxy vitamin D3 as the least severe COVID virus infection. So basically, what to lose? What the controversy? Let the studies come after 3 years, 5 years. Let the vaccine come after 6 months. But suppose you and me are deficient in vitamin D without checking itself. As an Indian, we know 99% of Indians have high melanin content in the skin. We are vitamin deficient. Take a vitamin D tablet once in a week for 8 weeks. That's a loading dose in an adult above 18 years. And after 1 tablet per week for 8 weeks, take a 1 tablet per month in summer climate and 2 per month in winter climate. That's a maintenance therapy. So invariably understand upper respiratory infection, lower respiratory, including viral, bacterial, fungal. Everything can be reduced by keeping your vitamin D not at 30, preferable range of 40 to 60, at least above 50 nanogram per ml. And now vitamin D supplementation, which I have told you, but hypervitaminose D is getting a norm nowadays, because Harrison used to say 90% of hypercalcemia invariably in the clinical practice is due to primary hyperparathyroidism or MIH, malignancy-induced hypercalcemia. Now look at the last 2 editions of Harrison. They have changed it. 90% of hypercalcemia in clinical practice may be due to hyperparathyroidism, malignancy-induced hypercalcemia, which is PTH independent, or it can be due to hypervitaminose D, because people are getting bombarded with vitamin D. 1 minute I record before going to vitamin B12 and finishing in 3 minutes. Basically, 2 weeks back, I had a nursing staff, that's a sister, a non-sister admitted with hypercalcemia where PTH was undetectable. Calcium was 14, sister developed severe polydipsia, polyurethers, hyperflexia, where the neurologist did a calcium, it was 14. He did a PTH was 0, undetectable. He suspected that she's an elderly and maybe a breast cancer. They did for mammography, multiple myeloma, urine BJP, everything was negative. They did a whole body MRI and 18 FDG PET also. Everything didn't show a focus of calcium cancer for a PTH-RP production. Invariably, the patient came, we just did a 25-hydroxy vitamin D, it was 600 nanogram per ml. We just asked the sister to just mail from the whatever her institution, the whatever chart she has been treated. She went to an orthopedician 2 months back with a back. Orthopedicians gave 2 injections, one of over and 50 milligram with a vitamin D3 Araketal 6 lakh. The physician had already put her in a menopausal phase with a big decal, 2000 international units per day. And the gynecologist, she went for some tiredness and hot flush. She again put her on a vitamin D3 sachets of 1 sachet per week. So none of the doctors were looking at the back chart. The orthopedician has already given 6 lakh IM of vitamin D3. The physician is already giving with decal tablet, 1 tablet per day. On top of that, the gynecologist invariably added a 60,000. 3 are 3 type. One is an injection, second is a tablet, third is a powder. So sister told that these 3 are different formulations for the back pain, myopathy. Ultimately, she landed in very bad hypercalcemia with a calcium more than 40, and she has to be dehydrated. And the drug of choice for hypercalcemia due to hypervitaminose D is hydrocortisone. You can give higher dose, even up to 100 milligram of hydrocortisone per day, because vitamin D is a fat soluble vitamin. Just like organophosphorus poisoning, it can accumulate in your body for months and get corrected later. Finish, Shabira. How many minutes there? How many minutes there?
It's already over, so we can you can take 2 minutes. Okay.
Yeah, with vitamin D is over. Now I will go to the last. B12. But basically understand what is vitamin B12 important. Go for the vitamin B12 first slide and last slide. So vitamin B12 is cobalamin. Understand this first sentence only. Vitamin B12 RDA per day is 1 microgram per day. So whenever we take vitamin B12 tablets, all the Neurabion, for Remylin D, Metildia, all the tablets contains 1000 microgram of vitamin B12. That shows that even though your required dietary allowance is 1 microgram per day, you require such high quantities of methylcobalamin to keep your vitamin B12 level normal, because the inconsistent absorption of vitamin B12 in the intestine. And vitamin B12 is exclusively got from non-veg food. Meat, milk, fish, egg. That is why now the Indian studies have shown that up to 80% of Indian vegetarian people above the age of 50 years have a vitamin B12 level less than 200 picogram per ml. Don't think that the classical definition of vitamin B12, which we study for MBBS, a hypersegmented neutrophil MCV more than 100 microgram per whole cube, that is never got. Whenever you have a patient with a vegetarian diet or long-term metformin or long-term omeprazole, pantoprazole, just go for a vitamin B12. Vitamin B12 level less than 200 picogram per ml is diagnostic of vitamin B12 deficiency. More than 400 picogram is against. 30% of people on long-term metformin may have 30% decrease in the vitamin B12 level. And understand B12, don't look at macrocytosis, hypercytosis, just check vitamin B12 in every person above 50 or every person above 60 with a vegetarian diet with a long-term antacid. Now, this is the last slide of vitamin B12, so don't worry. So whenever you are checking a patient, there shows a vitamin B12 less than 200 picogram per ml, always give an oral B12, maybe a Mathew or Remain D once daily for up to 3 to 6 weeks. Then check the vitamin B12. If vitamin B12 is increasing, you know that's a nutrition deficiency of vitamin B12. Suppose you are giving vitamin B12 orally, still your vitamin B12 less than 200 picogram, then think of pernicious anemia, the most common cause of vitamin B12 deficiency on earth, 1 in 100 people. During your MBBS days, you used to do a Schilling test. Now nothing, just to diagnose pernicious anemia, if your vitamin B12 is persistently low, just write an anti-parietal cell or anti-intrinsic factor antibody, which costs you only 1,100 rupees. Once pernicious anemia is diagnosed, give an injection methylcobalamin. Just understand those. Methicobalamin 1000 microgram IM weekly for 8 weeks, followed by 1000 microgram IM monthly lifelong. So basically, this is in short about metabolic syndrome, vitamin D, vitamin B12. I just concise, but at least one point, maybe major doctors are hearing, maybe some practicing doctors are starting practice, at least understand thin obese Indian phenotype, difference between vitamin D3 and 125 hydroxyvitamin. At least when you have a patient with hypopara, don't bombard vitamin D, just put a calcitrol preparation. Whenever you get for sunlight exposure, it's mid-noon sun exposure, not elderly, and invariably every person for 60 years, 1/3 are having vitamin B12. Every person on long-term metformin, vegetarian people, definitely check the vitamin B12 level. You may have serious clinically improvement mentally, neurologically, physiologically, myopathy, everything may include in the vitamin B12 supplementation. Finish, Shabir. Thank you.
Thank you, Bobby, for that wonderful lecture. So I think everyone has understood what exactly is vitamin B12, vitamin D, and all, and its role in metabolic syndrome. Any questions or any comments? I think we can have just one question. Mohan sir, do you have any comments?
Bobby,
Yes,
it was an excellent presentation as usual.
Thank you, sir.
How many days it will take
Sir.
vitamin D3 level to become normal after you initiate treatment in a deficient patient?
Yeah, so vitamin D3, if you are giving an injection of arachital of 3 lakh or 6 lakh, vitamin D can become normal as early as 2 weeks. If you give a vitamin D tablet 1 per week or sachet 1 tablet, it may take up to 4 weeks for vitamin D to get normal. But there's a fallacy. You are giving 1 tablet per week for 8 weeks. At the end of 5th week, you are checking than 100 nanogram per ml. Then many people think that cytophytosis, they immediately stop it. No, you give 1 tablet per week for 8 weeks, then enter a maintenance therapy of 1 tablet per month in summer and 2 per month in the climate. Then only check the vitamin D3. In the loading phase, after 5 weeks, you check, it will be 100 nanogram. It is just like initiation of insulin. It may be low phase, then it will go. So understand, whenever you give vitamin D in dose of 2000 to 6000 units per day, there will never be vitamin D hypervitaminosity. That's why Indian studies, Shashank Joshi in Japan recommend you don't have to check vitamin D in any person who is given a standard dose of supplementation and maintenance therapy. You give it in people who are refractory to vitamin D, especially steroid therapy, anti-epileptic, heart therapy for HIV, long-term itraconazole users, or people with suspected celiac disease or gastrectomy patient. Otherwise, you just give 1 tablet per week for 8 weeks, 1 tablet per month in summer and 2 per month in winter, sir.
Thank you.
So, Dr. Bobby, for the excellent lecture.